Thank you so much for that really generous introduction, and I will try to walk you through how this might impact patients and clinical care and sort of why we did this in the first place. So just starting out with our current understanding of disease prevalence, and these are data basically from a large insurance database covering 2 million patients. And you can see on the left people who ICD coded as NASH. And you can see that comes to about 200,000 patients. If you look at patients that are likely to have disease, such as, for example, those that have multiple cardiometabolic risk factors, you see that the potential, the numbers of patients that are not being coded or not being identified, but are out there is actually quite large, and here on the order of greater than 16 million. So this slide, just to walk you through, on the left-hand side, these are data actually that Dr. Al-Khoury showed earlier. And I guess the most important thing to take home here is that what we would expect to be a rate of decompensation in a patient with cirrhosis or F4, you can see there is going to be on the order of 2 to 5% at 2 years. On the right, you see data from an insurance database, and the majority of patients that are diagnosed with NASH actually already have cirrhosis, which is or have had advanced disease, which is quite unusual. But importantly, if you look at the days to first occurrence, that's less than a year. So people are decompensating, meaning they're identified really, really late in their disease, even when they're not diagnosed with cirrhosis at the outset. So we're not doing a very good job. And that's part of the reason why we really need to take action. So there are numerous barriers to effective care, and I'm sure many of these have been covered, but low disease awareness, and specifically low awareness of how to identify people with advanced liver disease, is a reality that we face and see on a day-to-day basis. I think part of the apathy or helplessness that is felt by maybe providers would be that we don't really have specific FDA therapy, but that will change. That being said, we do have a lot we can do for patients, and so we need to, at multiple levels, raise awareness and empower providers to take care of and identify people that are at risk, as many of the prior speakers have discussed. Another aspect that was part of the impetus for the name change was disease stigma. And disease stigma is a complicated thing. It's something that is not the same. It's not perceived the same in every person. It's perceived differently across different cultures, different languages, and it can have many significant implications with respect to creating barriers for care. So the nomenclature of NAFLD is not something that just happened 3 years ago. This is actually something that's been evolving over a very long period of time. And if you can see here, this is a publication from Jürgen Ludwig. He was a pathologist at the Mayo Clinic, and he was the first to coin the term NASH when he basically found a group of patients who did not ingest alcohol, who had steatohepatitis that looked seemingly just like alcohol under the microscope, and nobody wanted to publish this paper. So the only place you could get it published at that time was Mayo Clinic Proceedings, and the rest is history. So subsequent to that, we had a meeting in 2002 in Atlanta, a single topic conference to look at many aspects of the disease, including alternative names. And at the end of the day, we landed on no change in the name at that time. So now 20 years again later, that seems to be the magic number. There was a paper published proposing a new nomenclature for the disease, namely metabolic dysfunction associated fatty liver disease, and really brought up to light many important things, such as providing an affirmative diagnosis, removing this potential stigma of alcohol, and recognizing the close relationship with metabolic disorders. And these are all actually really good things. The problem is that in the definition, it eliminated the importance of steatohepatitis, which we know to be the disease driver that leads to fibrosis development. And it allowed for more liberal alcohol use, which in effect changed the natural history of the disease and potentially threatened to invalidate many decades of research with respect to our understanding for that and the progress that's been made on drug and biomarker development, because now we're talking about a slightly different population. So in any case, many of us raised concerns over this, and we thought that we would undertake a very large process with very strong methodology in order to get to the bottom of this and include as many stakeholders as possible. So without going into much detail, because I don't have a lot of time for that, our initiative involved 264 nominees from the major pan-national liver societies, proportionate to association size. This represented 56 countries. This included hepatologists, endocrinologists, pediatricians, pathologists, members of industry regulatory bodies, patient advocates, and individual patients as well. This was a 4-round survey that took place over a 3-year period. It involved assessing and collating and using a little bit more than 3,000 individual comments to modify subsequent survey rounds. It also involved 2 in-person meetings where we discussed issues that were contentious or that needed further discussion. And again, this took several years to do. So at the end of it, we ended with what we thought needed to be requirements for a new nomenclature. This needed to convey underlying disease drivers. It needed to be non-stigmatizing. It needed to account for the role of alcohol. And we needed to be able to parse out other specific etiologies leading to steatosis, because those are certainly not what we referred to as NAFLD. And then, of course, and very importantly, to be able to adapt to advancements in the field as we move forward and accommodate new disease phenotypes. So here is where we landed, and you've been hearing this nomenclature used for the entire conference, at least since I was able to join. So the overarching term of SLD, or steatotic liver disease, encompasses the replacement term for NAFLD, which is MASLD to represent the non-steatohepatitis version, and MASH to replace NASH completely. There's complete overlap between those two. In addition, it created a new category called MET-ALD. And this is actually, I think, to me, the most exciting part of this whole process, because it identified and gave a home to a group of patients that we know to be very common. And this matters for many reasons, but from a clinical trial and drug development standpoint, these patients are all excluded from clinical trials. So it gives us an opportunity to study and understand response to therapeutics and biomarkers in this particular population, but also opens the opportunity for us to manage their disease more actively, which I think is something we were not doing well enough. So there have been lots of studies that are starting to come out. This particular study is a nice paper from actually Alexander Krog, which I collaborated with as well. Mads Israelsen was the first author. And you can see here that in the database of 450 patients with a history of alcohol ingestion in the past, parsed out by a disease subclassification, you can see that there is prognostic relevance to firstly having SLD or not. You can see the probability of having decompensation is significantly less if you do not have SLD. And then in those who have hepatic decompensation, again, much lower rates of hepatic decompensation in those with no SLD compared to MASLD, MET-ALD, and ALD in a sort of a dose-dependent, if you will, manner. So that was, I think, exciting and important results. So what this does is this, as I mentioned, allows us to manage and actively engage the patient about competing risks. So we know that the most important cause of death overall is going to be cardiovascular disease and cancer in this population. But of course, with increasing amounts of alcohol intake, this can shift, and the increase of the prevalence of advanced fibrosis is going to heavily skew the prognosis towards a liver-related outcome. So it allows for a more, I think, seamless discussion of the importance of both aspects of disease pathophysiology. So I think that we need to approach this on multiple levels. So as we're doing tonight, talking to patient advocates and other providers, primary care physicians, but I also think we need to go directly to patients, because that's really, I think, the only way that we're going to make some headway here. So this is just a snapshot from a website that basically a program that has been developed by Mike Charlton, myself, Stephen Harrison, and a few others. I'm trying to reach patients directly and identify those that might be at risk for advanced disease, and then asking, sort of directing them to their physician, depending on their FIB-4 score, which we've heard a lot about today. It gives a printout that the patient can then hand to their provider and hopefully guide them through risk stratification, identifying patients who are at risk for disease that could present later in life with decompensation. So what is the impact on patients? Of course, this does represent medicalization of the lexicon. There's less familiarity with new terms. It's difficult to do anything new that you're not used to. That's just the reality of things. But there are also multiple advantages. It uses non-stigmatizing language. It allows for more seamless discussion of the root causes of the disease. And then this MET-ALD category really opens the doors for a lot of important research and attention to patients that were not really being addressed early, before. So with respect to what is, in a nutshell, the impact of the new nomenclature, I think it helps us with understand disease stigma and try to avoid it. And one of the conclusions was that if stigmatizing language could be avoided, it really should. And there's a really interesting abstract that that Zubair Younousi led in diabetic patients that showed that about 30% of patients were avoiding care based on the stigma of fatty liver. So again, I think this is an important aspect that maybe doesn't get talked about unless people are asked. So why is SLD helpful? Again, it doesn't change the nature of the disease. The overlap, which I didn't specifically address, of MASLD and NAFLD is nearly complete, about 98%, and it doesn't impede any progress we've made on clinical studies or NIT development. And the construct is more inclusive, but it's also expandable under the SLD umbrella. And then with respect to the progress on NITs and treatment, again, I mentioned already that there really should not be any negative impact at all. It really should be seamlessly superimposed. And MET-ALD, which again, we've discussed and mentioned now several times. So as far as next steps, we still have a lot of work to do. We need to continue our efforts to change ICD coding. We recently submitted an application for this just a few days ago, and hopefully we'll be successful in that. We need to continue to use the new nomenclature, increase dissemination. I can tell you that shortly after the nomenclature paper, at least preliminarily, came out, there were 3 references to MASLD, and those were the publication that announced the new nomenclature. Now I just looked, and it's actually close to 300. So it's really picking up steam, and that's really great to see. On the ASLD side, we have a lot of resources, printable resources, presentations you can download, infographics to kind of help walk clinicians through this process. And then again, the campaign to increase awareness and adoption really needs to be a grassroots effort, accompanied by societies, including patient advocacy organizations, in the form of webinars and numerous other platforms. So we luckily have almost 100 societies that have endorsed. They're not all on this slide, but it's very exciting to see the uptake that we've had. And with that, I'm going to close, and I'm going to thank everybody who's participated in this process. It was quite a lot of people, but my partner was Phil Newsom, and without him, I could not have gotten anywhere. The ASLD governing board and staff, Jeff Lazarus and Diana Romero, and the SLD task force that have been instrumental in the rollout right now. And of course, Isel and Ale for their leadership and ongoing participation. So with that, I will close and I guess take questions later. But thank you for your attention.